Welcome to Health Stealth Radio, where we move away from the mundane to gather insights from the shadows of enterprise and patient cybersecurity. Yes, we surely believe that traditional themes like endpoint software and zero trust are critical, but given massive advances in AI, remote and wearable device hacking, and data hostage negotiators, there's a much darker side to cybersecurity, and not everyone is quite willing to talk about it in public. Health Stealth Radio will thrive on these topics and encourage fireside spats to debate them. Here's your host, Frank Cutitta.
Hello, wherever you are. This is Frank Cutitta. Welcome to Health Stealth Radio, brought to you on Healthcare Now Radio syndication. Today, I have the thrill of having an old friend and presenter from my days gone by in the patient experience side, Dr. Stephen Beeson. He's going to tell you a little bit about his company. I can only tell you that I have him on the radio show, and for some of you on video, if you see this guy in front of a group of healthcare practitioners, it's very emotional, very powerful. So I know that our show here is somewhat related to the trials and tribulations of healthcare technology, cybersecurity, and so on. But I found that some of the most powerful things that I've presented to our CIO type audience have been people like Stephen Beeson, who talks about the softer side of this and how that ties into technology. So without further ado, Steve, why don't you introduce yourself? I'm really curious. I think one of the best parts of your story is the origin of your business. This wasn't just like pure entrepreneurialism. Like, I think I'll start a business related to wellness, clinician wellness. I mean, you have an emotional part of that launch as well.
Yeah. So much of life is by accident. And that feels like it's been my life. I was never intending to found a business, and probably had no rights to really do it, and have made 1,000 mistakes along the way. And some of which were near fatal. I mean, not fatal in terms of killing me, but certainly fatal in terms of the business itself. Because in our medical training and medical school and residency, the idea of starting and growing and sustaining a business is hard, and not in the skill set that I ever learned. So it was very much a life of PDSA. And so here we go. My story is sort of born and raised in San Diego. And, much of my youth, interestingly, was wanting to be a musician. I was a deeply committed and passionate and pretty good trumpet player. And beginning probably in around 8th grade, I really, really worked hard to become a great trumpet player, applying daily skills and etudes and all that sort of thing, having amazing instructors and teachers, and actually quitting the high school band for a year to be able to advance, because I thought being in the marching band was interfering with my personal growth as a musician. So anyway, when I finished high school, thinking that I was going to be a trumpet player, I began to dabble in professional music, and I realized the people that were making $50 a night were 10x better than I could ever hope to be in the next 10 years. And I thought, I got to do something different. And I intersected with my uncle, who's a neurologist, and had dinner with him one night, and he told me about the day in the life of a physician. And it sounded amazing to me, to know people and to gather their story and to make the diagnosis and issue a treatment plan to advance their wellness. That's a pretty cool way to spend a life. So I spent a couple of summers with him and had a chance to see him work. And he gave me all sorts of clinical opportunities with medical students and residents. And I really shifted my life from music to medicine really pretty quickly, and ended up getting to medical school and doing residency here in San Diego at UCSD. And the intention was just to be a doctor and to see patients my entire life, and began to shift a little bit. I was part of Sharp Healthcare. Sharp Healthcare is a big integrated system here in San Diego. And Sharp Healthcare around 2001 was having some flashing yellow, even red lights on our organizational dashboard in terms of what it was like for patients that were receiving care from us and what it was like for the care team members. Mm-hmm. And so we launched an effort to make both of those better. And I was appointed and selected to become the medical director of that endeavor that we call the Sharp Experience. And I had a chance to help facilitate physician participation and contribution to that journey. And that's when my personal journey of, sort of identifying the power of human development in giving people the capacity to really provide amazing care and to do their work in a way that allows them to feel joy, contentment, purpose, and to really lean into this is who I want to be in this life. And using a continuous human development approach to give people that capacity on how we connect with patients, how we collaborate and partner with each other, and how it is that we lead people. And through the application of continuous human development, Sharp Healthcare, through the work of many, 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 many people, it was not just me. There was tons of people that were contributing to this. We were able to take patient experience, engagement, turnover, quality, finance, from really bottom decile in some cases to top decile, and earn national recognition for organizational transformation. I wrote a couple of books along the way, Practicing Excellence and Engaging Physicians. And about 10 years into this journey, I was thinking to myself, the application of human development to achieve outcomes is super powerful and almost entirely untapped in healthcare. And what about the idea of tapping technology to create continuous improvement and learning and skill development and skill application to render meaningful outcomes in healthcare for patients, for teams and organizations, and all the cultural proxies that are so important, things like patient experience, team member experience, engagement, and turnover. And so sitting in a Starbucks around 2012, I thought, there's a chance here to really make a difference beyond one patient at a time in the exam room, but rather how can we tap technology to create wide, system-wide, scaled, synchronous human development on evidence-based skills to render meaningful outcomes in patient connectivity, team collaboration, and leadership effectiveness. And so that's when the idea of what is now Practicing Excellence was birthed. And now we're supporting tons of organizations and physicians and nurses and care team members and leaders trying to make healthcare better. That's great.
I want to get to the technology part, but I'm sure that as you launched this business, I suspect you had people who are saying, you're trying to present Practicing Excellence to us as a client. Aren't healthcare people supposed to know this stuff already? I mean, is there a giant hole in healthcare medical education that says, well, okay, it's like contracting a fire department to take care of the fire department. What's the I call it the skepticism maturity model.
You bet.
Tell me a little bit about skepticism. People think, okay, these tambourine shakers are going to come in and try to change us. So we don't need that kind of thing.
Well, it's interesting. I can tell you a couple of objective and subjective data points that make the point that the variance of behavior and skill with patients, with each other, and as leaders is massive. And when you have variance of skill, behaviors, and approaches on how we communicate with patients, how we collaborate and build safety within and across teams, and how it is that we lead, when we have lots of variance in our capabilities and skills, the outcomes are highly variant. So what I've seen over the years, and I'll just give you a couple of data points. There's 3 studies. This is one example of hundreds. 3 studies demonstrating that when physicians hear the story of patients with metastatic breast cancer and patients articulate a fear, worry, or concerns, and doing audio recordings of those interviews, hematologists, oncologists miss 90% of empathic opportunities. But ironically, they rate themselves as nearly perfect in seizing empathic opportunities and expressing compassion for patients who are suffering from metastatic breast cancer. 3 studies demonstrating the same thing.
So you're talking about the disconnect between what they rate themselves as versus what the real world is.
Well, not only the lack of insight, but also the failure to deliver on empathy when patients are expressing fear, worry, or concern. So imagine a system that is missing 90% of all empathic opportunities. Patients are coming in afraid, worried, concerned, freaked out, can't sleep at night. And the system doesn't acknowledge, address, or respond to those fears, worries, or concerns. Imagine a system doing that.
Scary.
And how powerful it is for a clinician or a care team member to say, oh my God, I can't even imagine what that's like for you. I want you to know we're going to be with you every step of the way. We're going to get this thing figured out and get you through this. The point being is that whether it be listening, building patients' confidence, activating patients in self-care, the expression of compassion, creating first impressions, managing clinical uncertainty, managing patients, requesting medically unnecessary care, extending the perception of time, being fully present with patients. I could list 1,000 things that, quite frankly, we are not very good at, and we don't even know that we're not good at, and we think we're really good. That is a bad combination for delivering the kind of care where patients walk out and say, holy smokes, you're the best. I feel confident. I feel assured. I'm going to participate. And thank you so much for being that clinician fully present with me. And the other flip side of this is not only is it raising self-awareness that we're not as good as we might think, but there are now 57 studies, including our own published study, that our deep connectivity to the patients that we serve saves time. It improves patient participation in care. It eliminates malpractice risk to zero. And it is the most important dividend of all is it is a compelling facilitator of physicians or care team members that are touching patients to go home at the end of a day, week, month, year, life and say, this is why I'm here. And so the idea of building skills to allow that to manifest so we know how to express empathy. We know how to listen to patients. We know how to have them feel heard. We know how to have them feel confident in their care. And just like we have a clinical care pathway for managing postoperative DVT prophylaxis or class 3 heart failure, we have an evidence-based pathway. There is evidence for what those behaviors are. And the idea of practicing excellence is to source evidence on the behaviors that work and syndicate them to everybody synchronously with verification of skill acquisition and skill application with pre and post measures of success to use human development as a mechanism of improvement. And so that's the thesis. And I can guarantee you, having shadowed 1,000 physicians over the past 20 years, the opportunity for learning and growing and getting better is boundless. So when I'm shadowing a physician, I'm introducing a positive bias into the room because they're trying their hardest because a coach is watching them. Even in that context, major misses. And again, it's not bad physicians. They're technically very, very sound. They're getting the treatment right. But patients are walking out disconnected, not confident, not included, not heard. And why so many patients are not actively embracing or participating in the care plan is because what we've done in terms of our capacity to connect with them. So anyway, that was a long, convoluted answer.
That's a great answer. As you might recall, I was it's very personal for me because I was a 100-day inpatient for COVID.
I know.
During the worst of times. Yeah, so I mean, I got to do primary research watching exactly what you're saying. They were totally capable. It's just that there was another side of the brain that wasn't being tapped into. So it's really important. So the question, you sort of teased it at the beginning and it fits into what you're talking about here. Technology. Is it the solution? Is it the problem? I know it's someplace in between. So what are you seeing in your practice of where technology fits into this, and I mean, you're using technology for your platform, so you're obviously an evangelist on how that content is delivered and how emotion can be delivered. But we have a lot of new forms of technology. What are you seeing in terms of this being the root cause, EMRs, EHRs being the root cause of burnout and stress? What do you see it on the ground?
Well, we could have a 6-hour conversation on this topic. So a couple of key points. Number one, I'm a strong advocate and evangelist for technology enabling powerful solutions in healthcare. And, we as a company use technology for wide scale distribution of microlearning content to teams with use analytics, with prompts and nudges, and other enablers that we could never do in the absence of technology. So that's the foundation of our content distribution. So so we're using technology to create a human development platform. I'm going to pivot to the electronic health record, which interestingly, I was with a buddy of mine last night who's a dermatologist, and he's got a small dermatology practice, and they just converted to an electronic health record, did tons of diligence on it. And he was one of 9 practices in the world that is not currently using an EHR, but they pivoted over 2 months ago. And he said to me just last night, he said, Steve, Now I know why physicians leave practice early, because of what the EHR can do to workflow and quality of life. Mm-hmm. And he knew that he had to make the change because he had over 20,000 patients, and people say, I need a refill of X. And they're going, what are you going to go look for the chart? I mean, it's, it's
go back into a file.
Yeah, you can't, it's just not doable. You have to have an electronic platform to administer healthcare today. It's a blessing and a curse. It allows us to do all the things we've been able to do in terms of data harvesting and, shared platforms. So teams are knowing what other teams are doing, and care team and physicians are able to communicate with each other. Yes, there's tons of upside that everybody knows. But I also know that from a behavioral standpoint, there has been some partitioning and disconnection with patients utilizing technology. And that is one of the substrates that we use in our learning platform, which is how do we maintain connectivity to patients via telehealth and with technology in the room. That is a very specific set of skills and set of actions, so the technology does not pull the clinician away from the patient. And so that's one issue with it, the adaptive use of technology. How do we help clinicians maintain connectivity to patients while using technology in the exam room? Mm-hmm. And the other is a lot of the enablement tools of ambient listening and AI-based scribes and other emerging technology that are real and being used right now that I think can be game changing in regards to reducing the administrative burden and dictation and the other things that we're faced with, using some of the AI tools and ambient listening scribes to allow us to generate notes. I think that's a very exciting application of technology. So it's been a blessing, and it's been a burden and a curse. And now we've accepted the fact that technology is going to be a key part of healthcare delivery. And we're still trying to figure out how do we do it in a way that allows clinicians to strike balance in their lives and maintain connectivity to their patients.
Totally agree. And the whole area of ambient is again, we could go 3 hours on ambient and how people are taking that unstructured data and turning it into insight based on what they're getting from those encounters. The area of telemedicine, which I've been intimately involved in as on the patient side, is interesting to me, mainly because I see at times that it creates the illusion of a connection with the patient. And we give the physicians the tools, or the clinicians the tools, and there's a whole nother aspect of that communications process. I call it telepresence. I haven't coined that term, but I'm sure it's being used in other places. But I've seen more cases of male pattern baldness on telemedicine from people just sticking their head down and clicking while they're talking to me than I would at a retirement center. So I just think it's, I don't know, that might be what your organization is also doing. How do you build that digital presence to create a whole new, I mean, we're still in the hybrid world. It's changing, it's morphing, but I mean, we still need to use that for the efficiencies that it has. But are we providing the proper training for the people to use those tools? Or are we just giving them iPads and saying, okay, here's the logon?
Well, with the advent of COVID, we did no training. We just threw them in front of a screen. Mm-hmm. And it was a bit of a disaster in regards to patient testimony. And again, we had to make a pivot radically. We didn't have time to certify them in telehealth-based communication, right? So, mm-hmm. But what we know is that human connection via screen is possible. I mean, I feel connected to you right now. I'm looking deeply into you and the camera, and we're connected. Is it different? It definitely is. And there's key skills that clinicians have to know as they're using telehealth to maintain connectivity to patients. And what's really interesting in our research is that there is no other distraction. When you're in an exam room, there's a lot of things that are around that are the sensory input for mm-hmm. patients who are participating in care. But when you're on a screen, it's just us.
Sanitized, yep.
And our ability to be fully present is the stakes are higher, and it's harder to do. And a little bit of diversion of not looking at the screen, not connecting to the patient, not leaning in, not using animated voice, not using your hands, and all the things that are human connectivity, the impact of the failure to deliver those known behaviors to maintain connectivity during telehealth is going to leave patients finishing the encounter to say, "Oh, it was all right, I guess. You know, it was more convenient. I didn't have to drive, but man, it was a little weird." And our point being on the application of human development, and in this case, how do we connect to patients via telehealth? We built an end-to-end telehealth certification, meaning what are the behaviors that we use and what are the things that we don't do, shouldn't do while we're speaking to patients? Because if you fidget or flip your pen, that's all they see. If you rock back in the chair or if you show your crown because you're looking and clicking, that's all they're going to notice because everything is amplified. So it's the application of, wouldn't it be great if we distributed to every clinician how to maintain connectivity to patients while doing telehealth as a part of your telehealth strategy? You know,
Right.
so it's the application of human development as an adjunct and a basic catalyst to executing an outcome. We so frequently don't do it, and we wonder why our outcomes are so variant.
It was interesting when I was at HIMSS, we did some research showing that the doctors disliked telemedicine more than the patients at that time. One of the reasons is that the patient, if they had a bad experience, it was just one bad experience with that doctor that day. With the physicians, it could have been 12 technology problems with all the patients during the day. So there was a lot of natural skepticism, again, of using this technology, because I've got to talk to 15 people today. And there's a chance that 50% of them will have some kind of glitch or a technology problem. And the patient just said, I had it one, I'm not going to do it with this one again, but I don't have to do it 12 times during a day. Is
their additive, I think.
A patient, unless you got a really bad helmet with something. So, we're 4 years out. I mean, I look at that calendar very closely because I got it in 2020. So I'm going on 5 years out now.
Wow.
Compared to where we were during that period of burnout and now, as you're building your curriculum, how has that evolved to new things, or are they pretty much stable, that these conditions are the same, or is there, as you would say with COVID, is there a new variant of discontent that's popped up? What are you seeing in evolving your curriculum?
You know, it's interesting, Frank. I think that there is, in my observation, and I think the objective data is suggesting that care team member and leader struggle and darkness is persisting. And I think it goes beyond just my clinical life is hard. I think it's diffusing and compounded by other elements of life experience, whether it be personal struggles with anxiety, depression, and the realization that the human experience right now is difficult. I think that there's a lot of things happening in the world that create heaviness in the life journey, whether it be politically, the climate, economically. There's just a lot. There's a lot happening now. I do think that there is, the idea of people building belonging and community and being there for each other has not advanced enough to counter some of the personal challenges that people have. And I think there's the persistence of all the things that make healthcare hard, profound economic challenges that, margins are still not even close to what they were prior to COVID. There's some degree of recovery, but there's financial pressures. There's immense regulatory pressure. There's a lot of mergers and acquisitions and consolidations. There's a lot of leader transitions. And when you stir up the pot of instability, meaning, we were just acquired, or we're about to get acquired, or we just acquired somebody, or we just got 3 new medical groups, and that's, oh my God, they're all different, and it's not at all what we thought, and all the cultures are different, and how in the world that's exhausting. And so there's those things are happening within healthcare. And then above and beyond that, I think that there's a lot of other circumstances, whether it be, personal mental health journeys, the lack of community, financial pressures of it's hard to afford the life that we all lead right now.
Sure.
And I think the composite of personal journey and challenge with the clinical life challenge of what American medicine is like right now, I would say the overall, we have not had a positive breakthrough in the quality of life of being in medicine with those two big channels contributing. That being said, because that sounds negative and dark, that being said, I would also contend that we personally and as organizations and even as an industry have access to the things that are known to drive human contentment and happiness. I know that to be true. And those things in my mind, and again, this is just not my opinion, but there's tons of literature that supports this, that number one, immense connectivity, purpose-driven connectivity, nuanced connectivity to the patients that we serve is a powerful driver of purpose in life as a care team member. Our best moments are behind that exam room door, and we have dominion over that. We can do that. The second thing that we've seen is this building of collaborative cultures of being there for each other within teams, clinical microsystems, and across teams, of teams being there for each other. We're going to lift each other, support each other, laugh together, lift each other up, and know each other and dive in if somebody's struggling, and go on runs together and Fitbit competitions and fantasy football and March Madness and root for the Padres. We're going to build a sense of collaboration and community within the place. We can do that. And the third thing is within healthcare systems, we have to lead in a way that lifts our people. We know exactly what those leadership skills are. So the thesis is that if we can deeply connect, we can immensely collaborate, and we can lead to allow our people to soar. That intervention, if you will, can prompt at least the people in healthcare to say, yeah, it's super hard. There's a lot of shit going on right now, but man, I love who we are, my team and our leaders, quite frankly, and I can do this. And so that's, even though it's dark out there, I believe that through deep patient connectivity, team collaboration, and leadership, we can lift the spirit of those in healthcare.
We've come to our time, and this has been. I thought it would be fantastic. It was even better than I thought. Just the way you present yourself, our audience will love it. This convergence of technology and compassion. I have a special section I do with Chime called Compassion IT, compassion with an IT on the end. Compassionate. So I'm looking for that intersection, and you were the perfect guy to do that. And I want to just thank you on behalf of Health Stealth Radio and Chime and myself personally for joining me today, and look forward to having that other 6 hours of conversation on the other side. We didn't have the time for today, and we'll get to that, Steve.
All right, Frank. And I appreciate you and all that you do. And it's so great to see you looking so well.
Thank you.
Thank you for joining us today in the shadows for this episode of Health Stealth Radio with Frank Cutitta. If you like the program, please be sure to share your comments on our social media sites, or feel free to contact us with suggestions for new and stealthy show themes. We look forward to welcoming you again for our next broadcast. In the meantime, stay safe out there.